The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and I want to welcome you all to our weekly Safe and Calm webinar. We're now in our third month. We're into our third month. The state stay-at-home order started on March 10, which was 78 days ago, and it's still very unclear what the next few months will bring us as we try to get back some semblance of normalcy. And as always, we here at Leading Age are working to support you, our members, who are in the midst of an ongoing daily challenge to care for our seniors during this time. Today we're going to change things up just a little bit and provide some time to ask members what's working and what's not, and in some specific areas. We have done a few surveys over the past 2 months, but we also want to create a little dialogue with you about what's going on day to day. And to help get that dialogue going, we'll start doing 2 webinars per week for a while to give us a bit more time to engage and have that discussion. So our webinars have been so packed that we felt that we needed to do that. Next week, we are scheduled for Wednesday at 10 a.m. and Friday at 11 a.m. We have, as usual, included the PowerPoints as handouts. One is in a PDF and one is in a PowerPoint format. And we will, of course, be sending that out later today to everyone. We have not yet issued the Q&A from last Friday. I did complete it, however, and we will include it with today's Q&A and send them out together. This morning, we're going to start with a situation summary. We're going to move to practice and guidelines, and then Dalton will end the session with an advocacy update. So our situation summary. The trends continue pretty consistently, but there are a few new pieces of information that we'd like to share this morning about the state of COVID in Michigan and other places as well. This first graph shows the confirmed cases for select countries. And you can see that the U.S. has long been at the top of the list in terms of total cases. And these are countries that have been known to have really high COVID caseload levels. And that bothered me for a while until I saw this next slide and then realized that we were continuing to compare a very large country, since the United States, to some very small countries. And when you look at Europe as a whole, the comparisons are a little bit less drastic, or at least they're in a different direction. These are the cumulative number of deaths, which is a little bit different than caseload, obviously. But you can still see that the United States isn't in the lead. So, you know, when you're comparing country to country, you have to continue to think about that. This next graph is one that I've been showing for about a month now, and on its surface, it looks similar every week. It is the 7-day rolling average for deaths. And notice that it continues to decrease, and you'd have to look at the other slides to really see that. But if you look at the length of the graph on the right side of the slide, you can see over time that the rolling average for deaths is decreasing. What is different this week is that the U.S. portion of those deaths is now down to 28%. When we started monitoring this, it was 33%. So not only are the overall deaths decreasing, the United States share of those deaths is decreasing as well. I've included this next graph only because I wanted to show some shifts. Obviously, United States and Europe continue to hold the highest numbers of cases, and you can see that there. But note that South America, and particularly Brazil, is increasing. And there are growing numbers in Mexico as well. So the pandemic continues to move throughout the globe. This graphic shows the density of cases across the state. And I think the important piece here is that although Southeast Michigan continues to hold the bulk of cases in our state, the more rural areas of the lower peninsula is trending upward. A couple weeks ago, we would not have seen any or very few circles up in the, granted the lower peninsula still, but the upper part. The upper peninsula itself continues to have low caseload. So this week we moved from number 6 across all the states in terms of total cases to number 7, which is a positive move. And these case comparisons are current as of Monday. Our fatality rate has always hovered just under 10%. And we currently have just under 1,000 hospitalized. We had many more than that a few weeks ago. This is a new graphic that collects death report data from nursing homes across the state. And you can see that Michigan is not reporting. Michigan, and we'll talk about this a little bit later, Michigan has had problems with reporting accuracy in nursing homes and stopped reporting until they will fix that. But a very important concern here is the number of states where the majority of deaths from COVID are occurring in long-term care facilities. Out of 35 states reporting, 18% had more than half of their COVID deaths coming from nursing homes. And that's quite alarming. Here is Michigan's 7-day rolling average of new cases as of yesterday. Last week, we noted a slight trend upward, but now we're continuing a general path downward. And of course, we hope that continues. So the numbers are going in a really good direction. The same is occurring in terms of Michigan fatalities. And in fact, it's almost been a more steep downward trend compared to overall caseload. So those numbers are improving as well. I did read in the media last week that an unpublished report, I think it's about to be published, from some Italian researchers showed that the fatalities seem to decrease in terms of percentage of caseload over time. So here you can see that the seniors carried a 30% death rate at the beginning of the pandemic in Italy, and now that death rate has moved down to 8.4%. And the same is true for persons with some chronic conditions. Researchers right now are speculating over time that clinicians may have improved care and perhaps identified critical cases earlier, and they're still studying this, but this could be a good thing for us as we move forward. If COVID continues to come back and rage, perhaps we know how to treat it better and can decrease the fatality rate. So at this point, we're going to pause for some questions.
All right, before we get to any questions, obviously we would like to say thank you. Each year, Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. Here's a list of just the first half of people who are signed up to exhibit and stuck with us for our postponed annual conference until we can set a new date for that. So thank you very much to all of them. Right now, I am actually not seeing any other questions, so it looks like we can just kind of keep on moving.
Okay, great. So on to practice and guideline issues. We're going to start this morning with testing. I know that we've talked a lot about testing lately, but there's a lot of conversation still going on around it at all levels. And so it seemed that we should talk about it again this morning. And we had a couple new announcements from the state that came out actually yesterday. So we're starting with looking at the priority criteria recommendations from the CDC. These have not really changed in the last few weeks. They still focus on persons with symptoms, especially those in hospitals and congregate settings, both residents and staff. So these are the priorities that states are asked to look at. However, when we think about priorities, we think about the fact that we have to reserve some of our capacity to test. We may not have enough supplies, we may not have enough labs, etc. So these priority areas are for that kind of a scenario. If there's enough tests, then and enough resources, of course, we would test a lot more than this, and that's what we're going to talk a little bit more about today. The CDC has several guidances out about testing. They have interim guidelines for viral testing. That's new. They do consider that antibody testing is not appropriate for testing for the virus itself. If members have not done any testing themselves, the CDC also have excellent guidelines for how to collect specimens, how to handle the specimens. And last week on the 19th, the testing guidance for nursing homes came out on May 19th, and facility-wide testing in nursing homes came out on May 19th. So just a discussion of the testing guidance for nursing homes. Basically, one of the major things that it does is it adds the reference to the CMS nursing home reopening guidance. And the link, of course, will be in our Q&A, which is also right there. So we're going to talk about the reopening guidance just a tad in a minute. We did discuss it last week. There are three general areas in terms of goals that the CDC looks at for testing. They think it's very, very important to, number one, keep COVID out of nursing facilities, two, detect cases quickly, and three, to stop transmission. So I think that the pieces that we really need to talk about is keeping COVID out and detecting cases quickly. Both of those goals have very, very similar testing parameters. The bottom line is the amount of testing that would have to be done to meet these requirements is pretty significant. They want you to test all personnel who screen positive for any symptoms and, of course, exclude them from work. You need to have a plan to meet staffing needs when staff may be excluded. But all of these goals and parameters include baseline testing of all residents and weekly testing of all staff as recommended as part of that reopening process from CMS. For detecting cases, it's the same thing. And pretty much for any new confirmed case in staff or residents, they expect you to test all residents and staff. So that's a lot of testing going forward. To stop transmission, an ongoing testing routine is again needed until COVID has been eliminated completely from your community, which again means testing of all staff or residents whenever there is a facility-related case found. Obviously, if you admit somebody who has COVID, you don't have to test everybody, but if a facility-related case, in other words, a case that was obviously occurred while the person was under your care, you are supposed to test all staff and residents. And then repeat testing of all previously negative residents until no new cases for 14 days. You can focus, if you have to, you can focus on testing for residents who may come and go, but almost all these protocols call for a baseline test and routine tests later. When you look at the CMS guidance, you'll note that a large part of the reopening criteria rely on testing. And these are the criteria for reopening in phases. And we did talk about this last week, but I wanted to focus on one point here that I'm not sure that we emphasized enough. CMS has provided these recommendations to states in how they can reopen. And a lot of those decisions are meant to be about, the case transmission in any state. So how you actually move to reopen will be different. It'll be might depend on areas that have no COVID or very little COVID compared to other urban areas that have a lot of COVID. So states will do that differently. But one thing that we have to identify is that they identified in this directive what you have to do at a minimum. So in order to open a facility, you have to have capacity for baseline testing for everybody. Residents have to be tested when a new case is found. Continuation of weekly retesting of all residents until they're all negative. Staff testing, including volunteers and vendors. So there's an awful lot to this testing piece that is going to be required. It's not 100% how it will clear out, how it will happen state to state, but definitely there's going to have to be a lot of testing. And yesterday, you can move it forward, Blake, please. Michigan updated its testing priorities. We do know that currently there's an initiative to test all residents and staff in nursing homes, but the state has also increased the number of categories for priority testing beyond that. You'll note that the highlighted area has the same priorities as the CDC. And then Michigan has added persons who may need testing prior to surgery, persons who might have been exposed but don't have any symptoms, persons working in congregate settings, and that would include long-term care. So that they have added quite a number of categories to Michigan priorities. And yesterday at the governor's press conference, she announced that free testing would be available at some major retail pharmacies. And this link at the bottom will take you to a list of where you can get tested. For Michigan's nursing home testing plan, there are currently 15 National Guard teams working to support long-term care facilities. Each one of these teams has a medic, and they completed the Upper Peninsula and most of the first tier of the counties that I identified in green. They will be going to the next set by the end of May is the goal. So they will complete 20 counties in the lower and all of the upper by June 1. In terms of reporting yesterday, go back, Blake, I'm sorry. In terms of reporting yesterday, the governor announced the creation of a new website, and that will include the overall testing data. And for the first time, they've separated COVID positive testing numbers that were confirmed by antibody testing versus viral diagnostic testing. And they're going to report those separately on the new website. The amount of antibody testing has increased in the past 2 weeks, and so they're going to change some of the numbers that have been reported to reflect that, because they don't want to use the antibody tests as a positive current COVID case. Another reporting issue is the reporting of nursing home deaths, and we talked about that a minute ago. The state has taken that data off its website because it was inaccurate, but they are hoping to report it soon. So let's take a moment and pause for some member responses. I will ask Blake to read a few of these responses depending on the number we get, but if you have some experience with any of these questions, we ask that you please make a note in the chat box. We may not read all of them now, but they will be summarized later in the Q&A. And these questions that we've developed are questions that surround areas that we have heard concerns from our members. And so we just want to kind of get a better sense of what's really happening so that we can communicate those issues to the state and to other parties. So the first set, and you don't have to answer these in order. If you want to answer any of them all at one time, that's fine. So has the state been to your facility to do baseline testing through that state initiative And if so, did that experience go well? Is there feedback that we need to offer to MDHHS? We did hear last Friday that one facility told us that it was really kind of confusing and they didn't have all the supplies right away. The next set of questions is, have you done any facility testing on your own? Have you had any problem getting test kits or labs to perform the test? And are you having any problems with turnaround time for results? I do know that a lot of our members have done some testing. And last, if you have done some facility testing, is it being ordered by your medical director or someone else? Have you had any problems with getting insurances to pay for the tests, and have they covered all the copays? There is part of the CARES Act, I think, says that nobody should have to have any out-of-pocket costs to pay for these tests. However, we have heard that there are certain insurance companies that feel that they are excluded from that. And so we have heard some stories that people have had to pay. So we're wondering if anybody has any experience with that. So we'll give you a couple seconds here, and then we'll see where we are.
All right, I have gotten a few responses here. I did want to mention, I saw someone said that they were having difficulty with downloading the attached links. We will be sending out the PowerPoint as well as the recording of this webinar, and both the Q&A from this time and last time. Probably today would be my guess. So you will get that, and I'm sorry that it's not working. Now on to these. Someone said, regarding testing, we're in northern. Oh, okay. Actually, that's a question, so I'm going to skip that one for now. We are in Kent County and have not been contacted about baseline testing yet, is what one person said. Another said, our plan to test our employees remains on hold by the local health department as they work out logistics with DHHS and get answers to their questions. Testing was supposed to have been completed last week. No word yet on when we can proceed, and that is in Washtenaw County. Another person said, answers to your questions, no, 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 and no. Another said, baseline testing, yes, but it was very unorganized. Let's see. We have tested some residents when they are potentially symptomatic. Another person said, we still don't have the supplies, forms, labels, transport kits. No problems with turnaround. Medical director has ordered potentially symptomatic residents. And then we are in Wayne County, and the National Guard dropped off testing kits, but we do not currently have any plans to test all residents and staff. We are considering it for the future. So that's kind of what I've gotten so far.
Okay, all right, good. Well, and this is a question that came up. I don't know if it came up last week or not, but someone asked if, it's not really mandatory. And it's true, it's not mandatory. However, you may not be able to open your facility unless you do the testing. And so it'll be interesting to see how that plays out. And CMS suggests pretty much that if you have people who are refusing the test when offered, that you have a policy in place to deal with that. And they suggested that policy be you treat them as if they're COVID positive. And so that's a rather drastic thing to do. So even though it's not mandatory, I think we think that there's going to be quite a bit of pressure to test.
All right, and then
okay, thank you. And
I was going to say, I did just have one question. They said, regarding testing, we're in northern Michigan. Our county is not listed, or not in those listed. Do we just sit tight until they get to us?
Northern Michigan, not the upper, yes. You're not a priority county. You probably have a low COVID caseload, but they are planning to get to all the counties by the middle of June.
All right.
Okay.
And then I had one other question. They said, will there be a nursing facility check-in call later today? If so, can we please get the dial-in number, passcode, and time? So I don't know if we have that.
Yes.
Or
if you're talking about the CMS call, I believe that there is a call at 4:30, and we can send that out with the PowerPoint.
All right. So I think that is it, and we can move forward.
Yes, please. So another thing that we received a lot of questions and discussion about is cohorting and dedicated units. What does a dedicated unit really look like? I went through the CDC guidance again, and to be honest with you, it's kind of basic. I mean, I do think that there's other guidance out there, and since last Friday, I haven't had a whole lot of chance to look. I will continue to look for it. They do suggest that if you don't have a dedicated unit now and you don't have any COVID patients, obviously that you need to think about that now and set up a location and a dedicated staffing plan before you actually need it. In Michigan right now, one of the later executive orders states that you cannot have a COVID resident in your facility unless you have a dedicated unit. The only time the CDC suggests you don't have a dedicated unit is that if the COVID is so widespread, you couldn't possibly put them all in one area. Obviously, there should be some physical separation. If you do have a dedicated unit, you might utilize nurse aides for unit cleaning in order to keep down the traffic. All of the things that you would expect in terms of infection control. One of the things that has been a little bit of a concern is how much facilities are having to minimize use of PPE, and whether or not, even though people are saying they have enough supplies for now, at what level are facilities using that PPE? In other words, is there a lot of reuse or extended use of respirators, eye protection, et cetera, being done? So that's something that we want to think about as we move forward so that we can make sure that the state is aware of what's going on in terms of PPE. And again, I will continue to work on some guidance for dedicated units. Another thing to remember is that there is an expectation that you also have an observation unit, that you really only want to put COVID tested positive patients in a dedicated unit. If someone has symptoms, until you know, you really don't want to put them there. You want to have an observation unit for them. You treat people in the observation unit as if they have COVID, but it has to be some area separate. It could be a private room for people who are not, they are a person under investigation, but they're not necessarily COVID positive, because you don't want to put somebody in there who doesn't have COVID and then ensure that they get it. So that's just a piece. Okay, you can move forward, Blake. So we're going to pause again for a moment, and we're going to ask members a couple questions. They're in groups again. There's only two. Have you set up a dedicated unit? Are you able to staff it with dedicated staff? And this is not just for nursing homes. This is for all levels, pretty much except for independent living. Do you have a separate observation unit? If not, how are you treating those patients? Second set of questions, are you currently having difficulty obtaining PPE? Are you minimizing use of PPE in any way? Are you reusing or extending beyond normal usage? And are you comfortable with your current supply sources for the near future? So we'll take a few minutes and let members respond.
All right, I'll start trying to just kind of read them off as they come in. The first one says, we do have a dedicated unit and have dedicated staff for that unit should the need arise. That is the only one I have so far. So.
Okay, we'll give it another few seconds here.
All right. We have a small pseudo unit, but it is in our HFA area. We are using it for residents under suspicion until test results are back. We are unable to staff that pseudo unit with dedicated staff. We have observation rooms that are outside of our COVID unit.
That's good. Okay.
We are good with good so far with PPE. This person says Macomb County, yes, we have a dedicated unit, dedicated staff. However, housekeeping and activities still go on that unit. We do not have room for a separate observation unit. We try to keep residents in a private room if we can.
Okay.
All right, and
Okay,
that's
well, let's move on, Blake, and
yeah.
we can collect more answers, and we will, of course, put a summary of all that. One more kind of discussion topic is independent living. Where are we with that? We've had some questions in the last couple days about how independent living is affected by all of these executive orders. On the left of your screen, you'll see that there are 3 executive orders that are kind of important for independent living and for actually all of long-term care. So 96 is extended to June 12th, and that is the stay-at-home order with some new flexibilities. And the governor now allows 10-person social gatherings. Executive Order 95, which was originally 2020-50, is extended through June 17th. Notice that there's no listing there for independent living. It speaks to dedicated units, retesting issues for hospitals, safe transfers from hospitals, and there's some discussion of other restrictions, including communal dining. Now, one executive order that really impacts independent living the most is 2020-72, and that extends until May 31. We have heard no noise at all about the governor eliminating this executive order. We actually would anticipate that, considering the fact that seniors are still at such high risk, we anticipate she's going to continue it, but we're not sure. This is the order that includes nursing facilities, home for the aged, AFCs, hospice, independent living, and assisted living. The 2 major pieces are limits to visitation and screening for all staff and visitors. So how does this apply to independent living? And the way that we think about it is that if you have seniors living in a congregate might not be the right word, in a single building where you walk through a door and go down the hall to independent units, that would be covered under this executive order. Our interpretation is that if you have independent living where you might have single housing units on a property, or maybe some duplex units where the doors open to the outside, we would think that those would be considered regular community homes. So that's the way we're thinking about it. Right now, independent living, just like any other long-term care setting, is not open to visitors. Communal dining is supposed to be regulated. Visits out, we know that you can't stop someone from leaving any of these settings if they really want to leave, but of course they're discouraged. And a lot of questions have come through with groups of 10. I've just gotten a message that we're having problems with the audio conference. Is everything okay?
I'm not hearing any issues.
Okay, I just got a message at the top. So it says the connection with GoToWebinar server has been lost. So anyway, we'll continue on. One of the issues that about the groups of 10, is can you have groups of 10 in your facility together? And I would say my interpretation, or our interpretation until we get some clarification, is no. You still have the same requirements for communal dining. You're not allowed to have communal dining under 72. You're not allowed to have group activities under 72. people in the outside world can have social groups of 10, but we don't have any guidance that says that you can do that in an independent living setting. So, any questions about that? And can we take a few minutes and see if there are any issues or discussion about how you're making this happen? Are there a lot of problems with visitors trying to enter the buildings? How are our independent living members able to do that?
All right. So I'd have per Executive Order 72, residential care facility includes independent living facilities. What is a independent living facility? Does a HUD housing senior apartment building with a service coordinator fall within the definition of an independent living facility?
Yes.
Okay, it says we have been advised that senior apartment buildings are not included in the independent living facility definition.
Okay. Let me follow up with that separately. If independent senior apartments aren't independent living, I don't know what independent living is. But we will look into it and try and clarify during the Q&A.
All right. We have residents who are wanting to attend church out in the community since they are open now. We are discouraging this, but in independent living, it is getting harder to regulate this. We have told them they may have to self-isolate for 14 days. How long can we continue mandating this?
I know that's really, really going to be hard. Technically, they are supposed to be isolated for 14 days. I don't know how long we can continue it. I'm thinking that some aspects of this should open up soon, but I don't know how much of it will open up. And I would anticipate if anything opens up, it'll be independent living. But one of the other issues that I would ask is that, do you even know in independent living what the COVID status is? I mean, do you know if you have any COVID patients or residents, in your facility? So, that's a huge challenge, and we need to talk to the department more about that. They're so focused on nursing homes right now because of the death toll that it'll be interesting to see how they progress with their guidance, because I know that there is a wish to reopen, but I'm not sure if independent living will open soon.
Okay. We are still not allowing our independent living residents to leave the building except for essential medical appointments. They are also not allowed to have visitors except for rendering of medical care.
Okay, and that's my understanding, although technically you can't stop someone from leaving the building should they choose.
All right. You may have already answered this, and I'm sorry if you did, but any guidance for families visiting with residents outside?
Outside of the building, like outdoors?
Yeah, that would be my assumption.
Technically, I think that that's not allowed, if I understand the executive order accurately, but that's something that we could ask and maybe get guidance. Blake, I'm still getting a message here that we're experiencing difficulties with the audio.
No, yeah, you're good. I've had a couple people type in and say that you were fine, so I would just ignore that.
Okay, all right, good. Okay, so I don't know if you can move the slide. Can you move the slide?
Yes.
Let me know when you do, because that's what I think might not be working. But
yeah.
we can move on.
I just did. It's on the staffing page now.
Okay, so my slides are not moving, but I can continue. So I will tell you when to move the slides, and I'll tell you what we have. So we're going to move on, and please continue to put your input in as we move forward. Staffing and workforce issues. We're going to talk a little bit about several pieces that are relatively new. And so we're going to move to staffing. Michigan's work-share program. Governor Whitmer yesterday spoke about the work-share program a bit, She expanded the use of that work-share program in the Executive Order 2020-57. And normally this program is used by employers who have laid employees off to slowly bring them back. This can be used if your business demand is down. You can preserve some of your workforce. You can keep them on your books while reducing their hours by 10 to 60%. So if you're not ready to fully open, if you have laid any staff off, this is also a program that our members could use. I do know that in some areas you all are still short of staff, but there have been some facilities in the past few weeks I've heard that had to lay off some staff because of decreased work in other areas. So this is a possibility. Moving to the next slide is about the ARC primer on human factors and teams. The Agency for Healthcare Research and Quality yesterday put out a primer on human factors and how to think about quality and performance during the COVID response. They talk about fatigue and burnout, and they have some ideas to deal with staff issues. So we thought that this might be a piece that might be helpful to some of our members. The link is on the lower left of the slide, and we will, of course, include that in our Q&A. The next slide is about the 2 per hour temporary raise for direct care workers. If I were going to identify one area where we've had more confusion, it's really about this piece, mostly because the program was really meant to enhance wages for persons who are doing in-home care. However, the program does cover any worker who is working with My Health Link consumers, My Choice, Adult Home Health, or Behavioral Services. And if you provided any services to those consumers between April and June. The department thinks, the people that I've talked to at the department is not even sure where the money is coming from. I anticipate that since these are all Medicaid programs, that Medicaid is going to pay for them. And if Medicaid pays for them, they're going to be getting federal match. So if indeed you have to support the wages for someone in this program, you may have to prorate it if they're not taking care of these Medicaid consumers only. So some of our members have gotten checks from My Choice waiver agents with little direction on how to proceed and provide those funds to direct care workers. And I'm still awaiting final guidance from the department. Every time I raise a question, it's like they have a whole new discussion about it. So if it is Medicaid, you may have to limit it to just those workers who are serving Medicaid residents. We'll have to see how that plays out. Moving on to the next slide, I just wanted to talk for a minute about a research/opinion article that was in the Journal of the American Medical Association, came out on Friday. It was by Vincent Moore and David Grabowski, and they, in case you're not aware, are major long-term care industry researchers. And one of the things, and I have this in quotes, is that COVID has exposed longstanding issues in how nursing home services are structured and financed. And they talk about the fact that the Medicare-Medicaid balance really drives an awful lot of what's going on, and that the mixture of long-term and post-acute care kind of also causes some difficulties. They believe that the majority of nursing homes do not have the staff, the clinical capacity, the PPE, or the physical layout to safely care for recovering COVID patients, and they identify this as a challenge moving forward. Their opinion is that there should be specialized post-acute care settings, especially for pandemic level kinds of care. And ideally, they see that hospital staff should be involved in managing and delivering care in these facilities for this really, really high acutely ill clinical group. So I thought this was an important piece. I would suggest that if you have a moment, you read the whole thing. It's rather interesting. It talks about all of the challenges in the system and actually kind of says, people are unfortunately dying from COVID in these facilities. Those are the most vulnerable populations, but nursing homes are just not set up to be the best provider of services. So that's an interesting piece. And again, the link for this article will be coming out in the Q&A. So any questions about those pieces?
All right. Before we get into any questions, Leading Age Michigan would like to extend our sincere appreciation to our generous business partners who continue their support of our annual conference despite it being temporarily postponed. So here you can see a list of the sponsors, everyone who has stuck with us throughout this difficult time. We would like to, we look forward to your continued collaboration, and we remain grateful to all you sponsors. If you guys ever need anything from them, feel free to reach out and use their services when you can. Now for a question, is there any guidance on SNF staff flying for vacations and their return to work? Do they need to self-isolate for 14 days prior to return to work?
Wow, I've not had that question in a while. We did get that question in the beginning when there was a lot of travel restrictions. I'll have to look that up. I think it would depend on where they went. I do know that if they are flying, that there are some challenges there. We will look that up and get back with you.
All right. So is this ban on communal dining and group activities still in place for independent living facilities? It looks like this is part of Executive Order 95, which does not include independent living facilities. Thus, I'm wondering if either I'm missing something or if we should be very gradually and cautiously evaluate allowing minimal activities and limited social distancing dining. We don't have any positive tests in our facility.
Well, the issue here is not so much whether or not it's in, I think you said 95, but that it's in 72. And 72 is current until May 31st. So they talk about communal dining in that latter executive order, but they didn't rescind 72. So 72 is still applicable. When we talk about communal dining, there are nursing facilities don't really have to stop all communal dining, but facilities have put like one person at a table, ensured that there was 6 feet between people, ensured that people weren't helping feed from one place to another. That wouldn't happen in independent living. And ensure that nobody with symptoms is ever in the dining room. But they considered that a restriction on communal dining. CMS kind of put those parameters out. However, according to this executive order, until at least May 31st, if not extended, all of those pieces still apply to independent living, no matter what it says in, I think it's EO 95.
Okay. And then somebody said that CDC just issued a travel advisory and then gave us a link, so we can go ahead and put that in the Q&A.
Great.
So thank you for that. So let me grab these next ones. So if not flying and going to a very open state, no 14-day quarantine required for staff upon their return from vacation. I know you are planning to research this.
Great. Thank you.
All right. So that is it for now. So we will continue on.
Okay. We'll go on to Dalton.
Good morning, everyone. Thank you for attending today. Today, we're going to be touching on a couple of advocacy priorities for us in the near future and today. We'll be talking about engaging legislators and discussing the kind of how we got to where we are regarding the legal immunity bill. And at the end of those, we'll also do a brief review of a really good article that Robin Stone wrote regarding senior housing.
Sorry, it wouldn't move forward for some reason.
Oh, no worries. So as we know, COVID has really shifted everything, and that includes the minds of policymakers and how policy's been getting done. Everything seems to be shortened, and the rate at which change happens has drastically increased, as I'm sure you've all felt. Because of that, we're going to be discussing some of the I should say more detailed advocacy priorities we have, and then looking at a larger macro picture using some of the early results of our membership survey that was sent out that is going to be closed on the 30th. So there's still time if you want to have your opinion in that survey, and also if you have the time to answer the survey. So to start off, some of our detailed advocacy points I've kind of grouped into two categories here, and that is future funding concerns and clarity and guidance. And I was glad to hear some of the questions that came out in the presentation. Deanna actually touched on some of these. For future funding, we are concerned about the future of long-term care resources and how to obtain those resources, specifically around testing and PPE. As you know, the National Guard is going to be out of here at the end of June, and in the go forward, we still imagine COVID will be around, at least in long-term care. So how do we obtain tests? How do we pay for tests? How do we obtain PPE if we need it? And how do we pay for PPE? And also there's general concern over overall provider rates and reimbursement rates due to the $3.2 billion budget deficit, and the Senate Majority Leader's recent comment saying he's going to look at cuts in the DHHS budget. And secondly, we're going to be we've been asking questions to provide more clarity and guidance around a lot of topics. Certainly more clarity and guidance around testing, specifically around staffing and the results of that testing and the impact it has on your staff. What happens if staff all test positive, or you have an outbreak in your facility and then you don't have staff? Where do the residents go? And questions like that. We've been asking for clarity and guidance around visitation, clarity and guidance around how to use PPE, how to obtain PPE going forward. What is the proper procedures for setting up and maintaining a dedicated unit, and transfer and discharge issues that have surrounded regional hubs and local municipalities. So here's the preliminary data from our membership survey. This question asks you to rank the importance of each advocacy topic from 5 to 1, with 5 being the most important and 1 being the least important in your mind. So you can see each of the topics we asked about, and the green bar is the 5. So the more green and the more blue you see, the more important it is. The more of this lighter blue or teal and this orangey beige you see, the less important it is. As you can see from this chart, Michigan's recovery and SNF Medicaid rates are of vast importance, especially, and also tax exemption. Those have really stuck out as our 3 main topics here that we need to focus on and go forward in terms of macro issues. You can see that life plan communities, PACE, and expanding affordable housing programs, which I realize is cut off, kind of aren't as important as those, at least to a majority of those who answered. Our survey early results show that about 50% of those who responded are CEOs. I'd say about 30% are administrators and 15% are DONs, and the rest are a mix of other types of long-term care employees. An interesting trend here is that when you compare this 2020 data to the last data we took in 2017, you can see a shift from what are considered optional programs in terms of priority to more traditional funding sources. So in 2017, expanding affordable housing and managed care and those kind of programs were of higher importance. And in a COVID world, Medicaid rates and the recovery and the potential tax exemption challenges that you face when local municipalities get their budgets cut and they're looking for dollars kind of become more important. And as I said before, the membership survey is open to the 30th. There's a link here and I'll be distributing that link via the listservs today. So, have you talked to a legislator lately? We know many of our members have incredible relationships with their legislators, and we also know advocacy starts from the grassroots up. So if you have heard anything, please let me know. If they've had questions, I'd be glad to at least hear what they're asking, so that way we can kind of hone our messages to them and see what questions they're asking. As we talk to many legislators, we're surprised about their level of long-term care, and have actually had really good conversations describing what is the difference between assisted living and independent living, or the fact that not everything is considered a quote-unquote nursing home. These are really productive conversations we've had, and we're happy to set up a call or even an introductory email for you with your legislature. And also we'll be developing a form letter to send regarding issues. In general, our advocacy has really shifted to focus on a holistic system approach. We feel that COVID has really highlighted areas of inefficiency and lapses in Michigan's healthcare system, and a larger holistic approach, which I think our members represent very well, since we have so many different kinds of service providers in our membership. We are the perfect association to have these conversations. And my email's on the slide. We're going to be touching on legal immunity here and kind of how we got to where we are. So, as you may know, when a bill is introduced, it's introduced into either the House or the Senate, then gets sent to a committee, who then sends it back to that same legislative body. So in this case, for legal immunity, introduced in the Senate, sent to a Senate committee, then sent back to the Senate, who votes it out and passes it to the House, who does the same process. For the Senate, it all happened within 1 week, and they added in language to expand the liability protections for healthcare providers and workers. And we'll see in a minute that this expansion is really what has caused the concern amongst members of the House. It passed the Senate 139 to 24, and then was immediately introduced to the House that same day, and then was reported to committee that same day as well. And that is an extremely quick process. I know they were looking to get something done very quickly on this bill, but that expansion, that substitution within the bill has really slowed down the process. So where are we today? The bill has been stalled in the House Judiciary Committee, mainly over concerns over holding healthcare providers accountable for supplying their staff with PPE, and the desire to hold bad actors accountable. Negotiations are currently ongoing with the chair and members of the House. It has become a nonpartisan issue, which is incredibly interesting. Republicans and Democrats are arguing on both sides of the bill. And the main concern, another main concern, is removing criminal immunity from the bill, which we think will happen if the bill is going to ever be passed. Many healthcare associations and healthcare providers have asked members of the House to add in language that provides what defines what a healthcare facility is more clearly. Right now, they're using that term healthcare facility to apply the legal immunity to those specific groups, and that doesn't include all healthcare settings, which is kind of the intent of the bill, is to provide healthcare providers who have responded to COVID admirably these protections. And right now the bill doesn't go that far, but it expanded what people were immune from. So we'll be working on this in the go forward, and we are working on it. We're talking with the chair, and we're hopeful that something will get done in the near future. Lastly, I did mention this article about that Robin Stone published. It is called "Under the Radar: Affordable Senior Housing Communities Need Support to Fight COVID-19." It's an incredibly good article. As you know, I'm sure many of you know actually, Robin Stone and her work is incredibly good. She has incredibly good statistics and lays everything out very succinctly. And I would recommend reading this if you have time. It's very quick, but very interesting. and the link is here and will also be sent out in the Q&A. Just a couple of things from it. She adds some detail to the numbers, or detail to what senior housing is by numbers. And the average age of a senior housing resident is 79. The average income is $13,300. And these are national numbers, by the way. They're not Michigan specific. 44% of those residents are African American, 26% are Latin American, and 55% of the dually eligible that live in HUD housing have 5 or more chronic conditions. When you're reading through this, and compare it to a list of factors that have negative influences with COVID, you'll see that these line up almost perfectly. So affordable housing units and affordable housing providers have a tough road ahead considering their population of residents. She continues in the article to discuss many of the challenges faced by housing providers. I don't think you want to sit on a call and have me list the challenges that you're facing when you have to leave the call and then go back and face those exact challenges. So what we'll be doing on the next slide is talking about what are the advocacy points Robin recommends and ones we'll be recommending in our housing advocacy going forward. And certainly a general theme of all this is that housing needs to have a larger spotlight and thought as a senior housing provider and not as something entirely different. So what are the advocacy points? I see the slide got a little mangled here. I apologize for that. She has 4 main points. Those are to identify what communities are COVID hotspots, increase testing and contact tracing for those, keep housing communities informed, increasing the amount of communication between local health departments and HUD properties. Interesting that many of our healthcare providers have found and struggled with issues with local health departments and their inconsistencies across counties. Offer assistance with sanitizing. Property managers need better education and clearer sanitation procedures for the communal areas. Not everyone is receiving the same guidance as what to sanitize, how to sanitize, what should be sanitized. So clearing up that confusion. And lastly, increasing public internet access to these, to the residents. This would empower them to minimize loneliness and isolation in the communities, which is another large side effect that we've seen in our populations, is that this loneliness and isolation is causing massive problems for them. I think this is a question slide.
Yes. All right. So again, we want to say thank you to all the exhibitors who have stuck with us throughout this difficult time. Obviously, you can see the second list of all the exhibitors here, so please use their services. Everyone that I've dealt with at all these places has been very great and is a great partner with Leading Age Michigan. Now, I do have a couple questions for Dalton. Do you think legislators will be more open to conversations given this is an election year?
Yes, especially if some of the restrictions are lifted on visitation, I would imagine them wanting to go out to communities if they have a chance to. Cynically, it's a great photo opportunity, but also there's a lot of voters in your communities and they can make one quick stop and boom, they get in touch with 100, 200 voters in some instances. So that is a massive benefit to us. The election year, every election year tends to be a little contentious, especially this one going forward. We anticipate them to start that process relatively soon. I know they're planning to get the budget done, I think by the end of next month, and then go really hard at the election before November. So we'll see what happens at the end of it.
All right, and then will you be sharing this report with people at MSHDA?
Which report? The Robin report? I assume it's with MSHDA since it's HUD. Yeah, we can go ahead and reach out to them. I know Laura Funch has been doing great work with our housing providers and really active over there. So we'll go ahead and reach out to them and see what they say about it. I know communication from HUD has been kind of tough as they defaulted to CDC guidelines. So we'll go ahead and reach out to them and see what they think about it. And once again, I do encourage you to read it. It's not very long, but it's very to the point and very powerful advocacy piece.
All right. I think that was the last question for Dalton, but I do have another one that I think you could answer, Deanna. It says, we just received an email at 10:45 that the state is requiring us to send a letter to all residents and responsible parties that explains how to file a complaint and includes a complaint form. Is everyone getting this letter, and has Leading Age Michigan heard about this?
I have not heard about it. We can certainly look into it. I'm not aware. So we'll have to investigate that and get back with you. We will put it in the Q&A.
All right. That looks like that is the last question. So I did just want to say a quick thank you to Deanna and Dalton, obviously, for the great presentation, like always. We would also like to give a thank you to, I believe we were topped out near mid-60s for the attendees today. So thank you to all the members and the participants who took time out of their busy schedules to join us today. We thank you guys for everything you do, especially during this difficult time, and we look forward to continuing our great relationship with all of you. Deanna, do you have anything else you'd like to say?
Just a reminder that you can email questions and comments to safeandcalm@leadingagemi.org. And we do have our individual email addresses there as well. And we will be sending out some information about and links for the 2 per week webinars coming up next week. And we'll see how that works. We'll see if maybe that provides a little bit more time for discussion. So thank you very much, everyone, and we will talk with you soon.
All right. Thank you. Have a great day, everyone.